Thank you, Smriti. Good evening, everybody, and good morning, Dr. Chochinov. Um, so today we are going to share about one of the most neglected topics in palliative care, that is mental health. Today we have two giants in this field with us, Dr. Um, Harvey Max Chochinov and Dr. Vikram Patel. First, I would like to introduce Dr. Chochinov, and Dr. Patel will be joining us after half an hour. So, Dr. Chochinov is a distinguished professor of psychiatry at the University of Manitoba and a senior scientist, cancer care, Manitoba Research Institute. His seminal publications addressing psychosocial dimensions of palliation have helped define core competencies and standards of end-of-life care. Dr. Chochinov has been a guest lecturer in most major academic institutions throughout Canada and in the United States. He has also lectured in South America, New Zealand, Australia, Europe, Cuba, Israel, China, Singapore, Taiwan, and many other places. He is the only psychiatrist in Canada to be designated as Soros Faculty Scholar, Project on Death in America. And he is the co-founder of the Canadian Virtual Hospice, which is the world's largest repository of web-based information and support for dying patients, their families, and healthcare providers. His book, Dignity Therapy, Final Words for Final Days, was the 2011 winner of Prose Award. In addition to over 300 publications, he is the co-editor of Handbook of Psychiatry in Palliative Medicine, published by Oxford University Press, and the Journal of Palliative Care and Supportive Care, published by Cambridge University Press. He has received top research awards from Canadian Psychiatric Association, the Canadian Cancer Society, American Association of Hospice and Palliative Care, and the International Psycho-Oncology Society, a Lifetime Achievement Award from Canadian Association of Psychosocial Oncology. In 2021, he received the highest honor that can be bestowed by Canadian Medical Association, the FLG Star Award. He is a fellow of Royal Society of Canada and a fellow of the Canadian Academy of Health Sciences. He is a recipient of Queen's Golden Jubilee Medal and the Order of Manitoba. He is also an officer in the Order of Canada. In 2020, he was inducted into the Canadian Medical Hall of Fame. And he did his residency in psychiatry at Department of Psychiatry in University of Manitoba and Doctor of Medicine from University of Manitoba and Bachelors of Arts English from University of Winnipeg and Doctor of Philosophy, Community Health Sciences from University of Manitoba. And to add to this, most importantly, last week he gifted Salim India with an autographed copy of his latest book, Dignity in Care, The Human Side of Medicine. And thank you very much, Dr. Sochna, for this precious gift and for your participation today. So with this said, I would like to invite Dr. Sochna for this presentation.
Well, thank you for that wonderful and very kind and generous introduction. It's my honor to be here, with so many wonderful colleagues in India, and I'm also very honored to see Dr. Rajagopal is able to join us this morning. So again, to everyone from Canada, a good morning. We've just had would you believe, a snowstorm uh, this morning here in early April. So winter is far from over in Canada, but this is a warm way of starting my morning, and I'm delighted that I'm able to spend this time with you. So in a very brief period of time, I'm going to tell you a little bit about what I've been referring to as dignity in care, which is essentially talking about the human side of medicine. Um, I have spent really the entirety of my career investigating, doing clinical work in trying to understand the experience of patients and their families who are facing end of life circumstances. We have published many papers looking at what I refer to as the experiential landscape of end of life care. And for at least the last 20 years or so, a very large portion of that has focused on dignity in the terminally ill or issues that are related to or informed by our understanding of dignity towards the end of life. Ours was the first group to actually do some empirical studies on dignity in terminal illness. Up until then, dignity was to be found extensively in the medical literature, but oftentimes it was used in a very particular way, in a way that was used essentially as a trump card to support whatever contentious position you might hold. So very often, if the debate was around assisted suicide and euthanasia, those in favor would argue, this is about autonomy. This is my body. This is my dignity. And so dignity would be the ultimate card that would be played in that hand. On the other hand, if you stood on the other opposite side of that political fence, you would argue the exact opposite, which is to say that, the taking of human life, the violation of the Hippocratic Oath, these are violations of human dignity. And so we said, we're not going to come at this with a political axe to grind, nor with a particular philosophical bent, because that would discredit us as researchers. So we published one of the first studies in which we actually went to the bedside of dying patients. This was a study that appeared, I'm shocked to look at the date, it's just over 20 years ago it appeared in the Lancet. And this was the first empirical study of dignity in the terminally ill. What did we find? Well, we had enrolled 200 patients. All of these patients were in palliative care, so they were all within 6 months of end of life, for the most part in their late 60s, early 70s, and about 80% of them had an end-stage malignancy of some kind. And amongst many other things that we asked them to fill out in terms of instruments, we asked them to fill out an instrument that was modeled on the schedule of affective disorders and schizophrenia. And this was an item that was to look at quantifying their subjective sense of dignity. And what you can see is that, in half of the cohort, they said that, dignity was never violated or undermined. So it wasn't something that they were thinking about, which means that in the remaining half, that's a substantive portion. In the remaining half, occasional thoughts of lost sense of dignity was something that they contemplated in anticipation of death. And then, in what we actually were surprised was a small minority, there was a significant loss of sense of dignity. I say we were surprised because we expected that, in the context of end-of-life care, people are dealing with many different losses, many different kinds of assaults on body, on mind, on spirit. And so we would have expected lost sense of dignity might have been higher. But then we remind ourselves that all of these people are receiving exemplary quality end-of-life care, which raises sort of an empirical question. What if this were to be done in a place where excellent palliative care weren't as readily available or wasn't able to be offered? The other possible explanation, and I remember one patient saying to me, dignity is God-given. In other words, she was saying that dignity is something intrinsic. It is something that is internally held. And so it really doesn't matter what you throw at it. It's like Teflon. It bounces off. So we then, in looking at the data, said, well, if we have this group of 200 people and we divide them between those whose dignity is intact and those whose dignity is broken, or like a bone is fractured, what is the difference between those two groups? Well, not surprisingly, when you looked at the psychological symptoms, people with a lost sense of dignity said, I don't want to be here anymore. They had a desire for death, a lower will to live. And these psychological symptoms, such as depression, hopelessness, and anxiety. And when you look at what's happening in the Benelux countries, where loss of dignity is the most highly cited reason, according to Dutch physicians, as to why patients seek out euthanasia and assisted suicide, this actually, kind of lends validity to the idea that maybe dignity is part of a final common pathway. In other words, you lose your sense of dignity, you lose your desire to live, a heightened desire to die, along with the psychological symptoms of depression, hopelessness, anxiety, and ergo requests for a hastened death. We also found, when you look at the physical issues that these patients face, that lost sense of dignity seems to be affiliated with more in the way of pain, difficulties around bowel functioning, and even physical appearance, or how people perceive themselves to be seen by others. And I'll return to that in just a moment. And then there's what we call the intimate dependencies of care. So these are things like bathing, dressing, toileting. And how often have we heard people say that, if it ever came to that, if I were unable to look after these intimate dependencies, I would no longer want to go on living. Well, we know, of course, that people are very much able to accommodate in most instances, and they shift in terms of their outlook. But when you look towards end of life, people with lost sense of dignity were more likely to say these intimate dependencies were problematic. Now, this brings me to what I think is sort of the most important slide thus far, and that is to say that when we did some modeling of the data, so we had done all of these measures with these over 200 dying patients to try and sort out this whole notion of sense of dignity. And we were able to do some mathematical modeling, which then determined what is the most vigorous predictor of lost sense of dignity. And here it came out that the way people saw themselves or perceived themselves to be seen, or physical appearance, was the most ardent predictor of lost sense of dignity. Now, this is kind of extraordinary because, in fact, for me, it was an epiphany. Beyond the Lancet article, I published a separate article in the Journal of Clinical Oncology that I called Dignity in the Eye of the Beholder. And what I said, even though this is, empirically based, that metaphorically, what patients are looking for in the eye of the healthcare provider is a reflection of themselves that will affirm who they are. So, in other words, if a patient looks towards a healthcare provider and only sees, at least metaphorically, only sees a problem checklist or a differential diagnosis, then it would feel as if personhood has been eclipsed by patienthood. And of course, that's where people suffer. And if we think about the issues related to, or the works of people like Eric Cassell, who wrote about suffering, suffering is about disintegration or threatened disintegration of personhood. So I found this etching a number of years later by the graphic Dutch artist M.C. Escher. And what you can see, this is a self-portrait of the artist. And you can see this is a portrait of a debonair, middle-aged looking man. He's in his apartment. He's surrounded by books, by photographs, by pictures, by his belongings. And so I tend to think of this as a reflection in the eye of the beholder, the healthcare provider, that affirms the entirety of who he is. In the absence of that reflection, people feel reduced to their ailment, and no one wants to be seen as just a patient. The times that we feel personally assaulted and put off when we encounter medical care is when we feel that we have been overlooked. We have become the ailment for which we presented. And in essence, this then is the challenge for healthcare providers. I mean, it's an extraordinary image because when you think about what is it that we see and the challenges of seeing past the physical, of seeing past the physiology, of seeing past the biology, and the middle, of course, is the person who is yearning to be seen, who needs to be seen. And so, believe it or not, I mean, I have spent a large portion of my career then thinking about how do we change the lens of the healthcare provider? How do we change the healthcare provider outlook? And again, the epiphany for me was, I've always thought about palliative care being about, the things that we do to patients or with their families. And what the data is saying is that the way we see patients, the way we perceive patients, in other words, our attitude, our outlook, our disposition is the most vigorous predictor of patient dignity. So let me share with you in the few minutes that I have remaining, and again, we have so little time booked today, but I think there's going to be about a half hour at the conclusion of this morning's two talks for there to be a discussion. Let me share with you a few ways in which our research group has tried to look at changing the lens of the healthcare provider. And to talk about how we do that. Well, the first thing to change the lens of the healthcare provider that we need is recognizing we're trying to take healthcare to a place that is difficult to reach, or maybe for many, really was not on their clinical radar. So to do that, you need a model or you need a map. And we did a study, again, terminally ill patients, vast majority end-stage malignancies, aged late 60s, early 70s, receiving palliative care. And this was a qualitative study, and these were the primary themes and sub-themes that emerged in this study of dignity, or this model of dignity in the terminally ill. By the way, all of my papers are available online, either go to PubMed, they're all open access, or to dignityInCare.ca, and we've tried to create a repository of articles so that they are available free of charge. So without going into detail, because there's certainly insufficient time, this is a model of dignity in the terminally ill. It says there are things that your illness causes that can impinge on sense of dignity. There are things related to what we call the dignity conserving repertoire. All of this is about the psychological, the spiritual. These are really the elements of personhood. Do I continue to feel like the person I was? Generativity. Do I feel like my life has made a difference, or that there will be a ripple effect as a result of my having been here? In other words, an effect that will even transcend the event of my death. Feelings like hopefulness, which is related to meaning and purpose, autonomy, and also maintaining some sense of spirituality or spiritual comfort. And then finally, so besides the things that are of the physical nature that the illness imposes, besides the psychological, existential, spiritual that also shape dignity, the map also says that there are things outside of that individual, and we call this the social dignity inventory. So respecting privacy, counterbalancing by social support. Care tenor is a term that we introduced into the literature that refers just to that, the tone of care. I once presented this to a group of oncology nurses, and one of the nurses raised her hand and says, "Oh, I call that the fragrance of care." In other words, it's that unspoken something, that ineffable quality that when you walk in a room, you're able to impart to patients that they matter, that you are there, you care, they have your undivided attention. Feeling a burden, of course, we know this is kind of existential extremis for many patients, which is why it's been cited in all literature that has looked at desire for death, loss of will to live, interest in hastened death, medical aid in dying, and so on. And then something called aftermath concerns, which is not so much a burden to others in the here now, but the concern that my death will place, or the burden that my death will place on those that I will soon leave bereft. So that is a map. If you take that map, we were able to use it in a variety of, I think, creative ways. For example, we created a brief psychotherapeutic intervention called dignity therapy. Now, dignity therapy is described in my book, Dignity Therapy, Final Words for Final Days. It's probably at this point, and again, it's been around for the better part of the last 20 years, 15 to 20 years. There are about 100 different papers in the literature, at least 20 empirical studies that have looked at dignity therapy. And there have been anywhere from 8 to 10 systematic reviews. In fact, I was recently at a meeting where somebody told me they had been funded to do a systematic review of the systematic reviews, which I found really astonishing. Dignity therapy essentially is a brief intervention that is guided by a trained therapist that allows the patient to speak to the things that they want said before they die in order to create a legacy document. In other words, this becomes part of their generativity. The conversation is recorded, it's transcribed, it's edited. We then read it or share it with the recipient, with the patient, for them to make any corrections. And then we make copies, and it is then for them to bequeath, to share with their loved ones. We've done multiple studies of this. We've done studies of patients. We've done studies of families. And as I say, there have been at least 8 to 10 systematic reviews. The collective data indicates that depending on the population in which it's done and the outcome measures that are used, and the baseline distress of the people who are enrolled, dignity therapy seems to affect, seems to improve, enhance end-of-life experience. There was an important study in Portugal with highly distressed individuals, which then showed that in randomized controlled conditions, dignity therapy was able to mitigate depression, anxiety, demoralization, and desire for death. Now think about it. Dignity therapy is being used, or was designed originally to be used, in patients who are terminally ill. And terminal illness, of course, is this profound existential assault on personhood. You know, not only do I not feel like I'm the person I once was, I'm anticipating that I will no longer be. So it's interesting that when you look at what's happened to dignity therapy over the last couple of decades, it's began to extend itself into other areas where people feel that personhood is under assault or is truncated. This is a study of dignity therapy that was done on people who were in prisons or incarcerated. And many years ago, a chaplain from a prison sent me a picture that an inmate had drawn as he was approaching death. And this served as the cover of his dignity therapy document. And it's a striking and profound image of a man surrounded by a cell. Next, when you think about assault on personhood, you think about mental illness. When for people who have serious mental illness, the end organ, the organ under assault, is essentially personhood. And so there have been studies, and this is an Italian study done by my colleague Luigi Grassi, in which they implemented dignity therapy for patients who had severe mental illness. And then finally, and this is some work that's been done by colleagues in Scotland, Bridget Johnson, personhood is under assault when things like dementia, Alzheimer's. And so Bridget has done studies looking at implementing dignity therapy with patients and or with their family members who can do it as a co-construction or as by way of proxy. Now, the next, and again, if I'm going quickly, it's only because we have little time and there's just too much to share, and hopefully we'll have a chance to revisit some of these things during our discussion later on. The next way in which we've tried to change the lens of the healthcare provider is by providing what I think of metaphorically as a newer microscope or a telescope. In other words, something that allows you to see things that would be difficult to spot with the naked eye. So we created, based on the model an instrument that we call the Patient Dignity Inventory. And there are multiple translations of this instrument, and they're available in the public domain. So the Patient Dignity Inventory is a multidimensional instrument that simply asks patients, which of these items, or to rate these items from not at all a problem to a severe problem. And you'll notice that it covers everything from physical distress to psychological distress, feeling depressed or feeling anxious. But notice, for example, when we start to get into the existential and spiritual realm, number 11, feeling like I am no longer who I was. Now, I guarantee that when you, if you're working in palliative care, you likely will not leave the room of a patient without asking them about their pain, about nausea, about bowel functioning. But I can tell you that 80% of patients affiliate no longer feeling like who they are as a dignity issue. They'll say, that is the thing, not feeling like me. That is the thing that would undermine my sense of dignity. And if we apply the telescope, and here is a paper in which we have done so, you're able to report on the landscape of distress in the terminally ill. And this, for example, gives you what you will see. So this is no longer which items do you affiliate with dignity, but this is saying, what is the prevalence of these issues as problems? So more than half not being able to carry out usual routines. Physical symptoms, 47%, nearly 40% not being able to carry out important roles, followed by nearly 40%, 36%, no longer feeling like the person that I once was. This is greater than not being able to carry out tasks of daily living, anxiety, feeling a burden to others, and the like. So this is a substantive issue for patients who are nearing death. Again, I'm just going to take, I think I have another 5 to 7 minutes, so I'm going to take that by telling you about 2 more quick things. How else do we change the lens? Well, we have developed something that we call the patient dignity question, something that PaliMed in the United States has described as defining dignity at the end of life with one question to ask hospice patients. And the patient dignity question essentially says, what should I know about you as a person to take the best care of you that I can? Simple question, how do you study it? We go to the bedside, we say to the patient, we know a lot about you medically, but we don't really know who you are as a person. So tell me, what should I know about you as a person to help me take the best care of you that I can? We go off, we summarize it into 2-3 paragraphs at most, and then we come back to the bedside within a few minutes, as soon as it's done, for 3 reasons. 1, we read it to the patient. 2, we see, are there any corrections that you need to make? And 3, and this is the litmus test, do we have your permission to place this on your medical chart? I can tell you without exception, every patient, or if it's done by a family member, they all say, this needs to be on my chart. During COVID, we actually did a study of the patient dignity question in intensive care. So these are patients who are now on ventilators. We called the family member at home with the permission of their intensive care clinician, and we asked them the patient dignity question. We know a lot about your loved one who's now fighting for their life on a ventilator in our intensive care unit, but they can't speak for themselves. We don't know who they are as a person, as a human being. So tell me what we would need to know about them as a person so we could take the best care of them possible. This was a direct transcript taken from the daughter of a woman who was now being ventilated in intensive care. And it says, Terry wants the healthcare team to know that her mother is not any ordinary patient, but is a very special woman. Since my mother was admitted, I've been struggling to find a way to share my mother's story with the staff, but my heart is so happy that this PDQ will now allow me to do so. I hope the staff read my mother's story and appreciate the life she lived. And this is a dated slide. There are now 35, not 23 patients who have done this. And 5 is the top rating. And you can see that people have rated these things as highly as is possible. In other words, they said, a family member said, the PDQ is accurate. They said, this is important information for my healthcare provider to know. They said they think this is going to affect the way the healthcare provider offers them care. They said this should be offered to all other patients and families, and that completing it for the family member was an emotionally meaningful experience. And having done some of these, I mean, I had family members who were just, who would be crying on the other end of the line. They were so touched that they had the opportunity to participate. And we have found that healthcare providers who avail themselves of this information end up saying in 90% of instances, I learned something that I didn't know before. It heightened my sense of connectedness, empathy, respect, and they would recommend it in other patient circumstances. At the risk of just taking a few more minutes, let me tell you one last thing that I've been publishing about. And that is, if we're going to look at changing the lens of the healthcare provider, we need to understand the biases that can also shape that lens. And I don't say biases in an accusatory way. The truth is, as human beings, I mean, we all have bias because we're socialized in a particular way in which we're constantly shaped and told what things have more value than others. And so we need to look at our lens, for the most part, our intuitive reflex responses to say and to gauge what somebody might want based on what we would want or someone we care about would want. In other words, the golden rule: do unto others as you would have others do unto you. But what happens if somebody's experience is so divergent than your own? What if, you think to yourself, I'm not sure I would want to be that sick. I'm not sure I would want to be that old. I'm not sure I would want to be that marginalized or disenfranchised, or whatever the issue is that is shaping your bias, leading you then to make recommendations that might be at odds with what the patient would want. So the golden rule, critically important, found in religious traditions across millennia, it does impose an external standard. And it can lead to therapeutic nihilism if you yourself wouldn't want something that you feel would lead your patient down a path that you would find untenable. And so it can lead to discordance regarding goals of care. So this is where I introduced recently, it was only in June of 2022 that I introduced in the Journal of the Journal of Palliative Medicine, the Platinum Rule: do unto others, do unto patients as they would want done unto themselves. This is a copy of the article, again in the Journal of Palliative Medicine, and it's the article of an elderly man with a head and neck cancer whose physician says, things might not go well. You may want to consider something like medical aid in dying at some point, which was completely at odds with this person's worldview and outlook. And what the article basically tries to say is, so what goes on in the mind of the oncologist making the recommendation? What do we understand of the lens that shapes the way he's seeing that patient? And the Platinum Rule then becomes an important standard to say we need to place ourselves in their perspective, not just our own perspective. So what are the merits of the Platinum Rule? It always considers the patient's perspective, which is why it's becoming important in discussions around EDI, or equity, diversity, inclusiveness. It helps us recognize and confront our own biases. Of course, it's a standard for substitute decision-making. And those of us in palliative care know that, when the mother or father or person in that bed can no longer speak, the appropriate question is, so what would you want us to do? The appropriate question is, if we could bring them back into this room, what would your mother want? What would your father want under these circumstances? Which, of course, raises the bar on person-centered care. And I'm also pleased to say that just this last February, Scientific American, which is a large American periodical, actually published a paper on the Platinum Rule that was titled "Better Patient Care Calls for the Platinum Rule to Replace the Golden One." During COVID, these have been some projects that I've been working on that have described some of this work more extensively: Dignity in Care, the Human Side of Medicine, and the third edition of the Handbook of Psychiatry in Palliative Medicine, which I published and co-edited along with William Breitbart. Finally, for those who don't necessarily think they want to take the time to do extensive reading, I pulled out one of my articles, which in some way I think essentially summarizes the essence of my parting message to you. And this is an article that was published in Palliative and Supportive Care, and it's called "The Secret Is Out: Patients Are People with Feelings That Matter." This is who I am. This is how you can get hold of me. And with that, I really do thank you for this lovely invitation. I'm looking forward to the next talk and to our discussion afterwards. Thanks so much.
Thank you, Dr. Chochinov. And I would like to tell you that uh, in Parliament, we usually talks about dignity therapy, and I am seeing you for the first time to introduce that concept. And now we all know that as palliative care doctors, we always look into psychosocial aspects of the patient care, but you ask us to stress more on the person, who is the person, how to take care of the person. So thank you for those messages, and we will take questions during the discussion rounds.
Thank you.
Now, I would introduce Dr. Vikram Patel, who will be speaking about mental health disorders and sufferings, um, the how to the current status and what are the possible outcomes. Um, so Dr. Vikram Patel is the Pershing Square Professor of Global Health in Blavatnik Institute's Department of Global Health and Social Medicine at Harvard Medical School. He co-leads the department's Mental Health for All Lab and co-leads the Global Mental Health at Harvard initiative. His work has focused on the burden of mental health problems across the life course, their association with social disadvantage, and the use of community resources for, for their prevention and treatment. He is the co-founder of the Movement for Global Mental Health, the Center for Global Mental Health at the London School of Hygiene and Tropical Medicine, the Mental Health Innovation Network, and the Sangat, an Indian NGO which won the WHO Public Health Champion of India Prize. He is a fellow of the UK's Academy of Medical Sciences and has served on the committee which drafted India's first national mental health policy and the WHO High-Level Independent Commission for Non-Communicable Diseases. He has been awarded the Chalmers Medal, the Royal Society for Tropical Medicine and Hygiene UK, the Sarnath Prize, the National Academy of Medicine USA, the Pardes Humanitarian Prize, the Brain and the Behavior Research Foundation USA, an honorary OBE by UK government, the Posey Leadership Award by Austin College USA, and the John Der Canada Gardner Award in Global Health by the Canada Gardner Foundation. He was listed in Time magazine as 100 most influential persons of the year in 2015. And Dr. Patel's research has focused on the nature of mental health problems, their social determinants, and the use of community resources for their prevention and treatment. His work spans the life course and includes child development and adolescent mental health, in addition to mental health problems in adulthood. His work played a central role in the emergence and development of the field of global mental health, and that has galvanized policy, civil society, and donor action to address the large unmet needs for care for people with mental health problems, both in low and middle income countries and in low resource contexts of high income countries. He is a co-founder of Sangat, a pioneering Indian NGO which won MacArthur Foundation's International Prize for Creative and Effective Institutions in 2008 and WHO Public Health Champion of India Prize 2016. And an additional area of expertise is universal health coverage with a focus on India. And he has been affiliated with various bodies uh, as in Wellcome Trust Principal Research Fellow He is the professor in the Department of Global Health and Population at Harvard Chan School of Public Health, co-founder and member of Managing Committee, Sangha, Goa, India, adjunct professor, Public Health Foundation of India, honorary professor, London School of Hygiene, Tropical Medicine, UK, and actually, I would like to introduce a quote from Dr. Patel. He says, mental health is too important to be left to professionals alone. So actually, this fits to Media's philosophy of making community partners in healthcare delivery. And he's also chairing the Lancet Commission on Healthcare in India. So, Dr. Vikram Patel, welcome you, and it's over to you for your presentation.
Well, thank you very much for that introduction. Let me, in the interest of time, go straight on to my. Can you hear me?
Yes, we can hear you.
Okay, great. Let me move straight on to my presentation on transforming mental health everywhere. I'm not going to spend any time today talking about the burden of mental health problems. I think that should be familiar to all of you. Roughly 10 to 15% of our population will be living with a mental health problem. But the more important statistic isn't the numbers of people who are suffering, but the numbers or the proportion of those who receive care, which is a minuscule fraction of that total number. The National Mental Health Survey in India reports that more than 90% of people with a mental health disorder identified by the National Mental Health Survey had received no care at all in the previous 12 months, making this perhaps the most neglected health problem in the country. Indeed, this is true globally as well. I want to start with a personal story to really talk about how mental health is inseparable from physical health. And I want to really tell you the story of my mother, who died a few years ago in Mumbai. This is her photograph, and I wrote a piece about her suffering, her long, epic suffering in the Lancet a few years ago. In short, my mother, who was born in 1936, then got married just outside her teens, in fact, in her late teens, and then had 3 children in rapid succession, not unlike the experience of most women in India of her generation. Both her first 2 children, my elder 2 siblings, were girls. And soon after the birth of my second sister, she started developing symptoms that in hindsight now, I could clearly identify as being postnatal depression. In a very gendered environment that she was in, the birth of a second girl child was associated with enormous unhappiness, actually, in the family. She even remembers coming home alone from the hospital with her newborn daughter. But instead of receiving care for depression, which was very poorly understood back then, her general practitioner started her on sleeping medicines. This is, of course, the beginning of what became a lifelong struggle with another mental health problem, that of addictions. She started drinking alcohol in 1964, bizarrely prescribed by her primary care practitioner to get her off the sleeping medicines, on the understanding that alcohol was perhaps a more socially acceptable way of actually getting to sleep, completely, again, missing another important diagnosis, that of the addiction that she had developed to her sleeping medicine. Many years later, 3 decades later, in fact, she had now become fully alcohol dependent and was now also diagnosed. By then, she was probably living with diabetes for many years, but now she was diagnosed with diabetes because of complications of diabetes that had arisen. Her depression was only diagnosed 30 years after her first episode of depression. This, mind you, my mother comes from a very privileged background, as you can imagine. She suffered her first cardiovascular event in 2003. Finally, she was stopped drinking thanks to the inputs of my father. She had a first episode of cancer in 2013, which was successfully operated. She developed diabetic nephropathy and end-stage renal disease in 2014. She had gangrene of her toe in 2015, and she died in 2017. This is an epic engagement with multiple chronic diseases. And what's interesting is that, through every single, admission, every single contact with one of the private doctors in India, she would get more and more new medications and diagnoses. And one of her most recent discharges, I actually took a picture of her discharge summary. And you can see the discharge doctor had very helpfully counted or numbered the number of medications she had to take. 24 medications was what this, by then 75-year-old woman, was required to take for her multiple different medical conditions. And never once had actually any of these different physicians spoken to each other. So there was zero coordination between the nephrologist, the neurologist, and God knows how many other ologists she saw. And this, of course, characterized the care that she had received across her life course. But as my mother's caregiver remarked, she may be miserable with all these treatments, but she lived for such a long time. And my mother's caregiver remarked and said, even one of the many conditions that my mother lived with would have killed a woman in her village, that is to say, in the caregiver's village, suggesting that, in fact, my mother was lucky that she was still alive. And of course, what my mother's caregiver was referring to is something that anyone who lives and works in India would immediately recognize, that we do not have a single country when it comes to the quality of healthcare. For a large chunk of our people, for a smaller chunk of our people, this is what healthcare looks like. This is, of course, the healthcare that my mother accessed, healthcare that could easily be confused with five-star hotels, and where, of course, the costs of healthcare are actually several-fold more than the per capita income of the average Indian. For most average Indians, though, healthcare looks like what you see on the right-hand side, where there are crowded, under-resourced, and dilapidated health centers that are run by the public sector. Friends, what I would like to argue with you today is that the only way we can fully address the needs of mental health problems is by the integration of mental health problems with other health problems. And of course, this is, to follow on from the previous speaker's remarks, the hallmark of person-centered approach. India has one of the worst examples of siloed, fragmented healthcare in the world, where if you are suffering from a health problem, you are likely to go straight to a specialist. A headache will be taken to a neurologist, a sleep problem will be taken to a psychiatrist, and so on and so forth. A person-centered approach really argues that we need to deliver care for people with chronic conditions and associated risk factors, which focus on the integration of their different healthcare needs in primary care. And that typically means addressing multiple morbidities concurrently, rather than in the fragmented way that that healthcare, particularly private healthcare, but it would be fair to say public healthcare as well, is currently fragmented. The case for the integration of mental health, physical healthcare is enormous. Of course, it improves access because you are actually getting care in the same place, the same location. It's more equitable because typically comorbidities are associated with greater social disadvantage. It's clearly more economically efficient. It's holistic and patient-centered. And of course, for the mental health problem, it reduces stigma because you're now receiving care for your mental health problem by the same provider and in the same setting as the person who is providing your physical health care. The big question is the how. How do we achieve the integration of mental health and physical health care? Obviously, primary healthcare has to be the platform for delivery, but it still is an important question, the how. Over the last 40 to 50 years, there has been an abundant amount of evidence exploring different ways of integrating mental health and physical health care. And I can now tell you that the most robust evidence-based delivery model is collaborative care, which is shown, the principles of collaborative care is shown very wonderfully on this particular infographic that comes from the team care model that was developed by researchers in the University of Washington in Seattle, looking at how you can integrate depression care for people with diabetes. What you can see here is that collaborative care typically involves a collaboration between three important levels of providers. The primary care provider is the nodal provider, the provider who will coordinate all the care that the individual with a chronic condition with multiple health needs. You have the behavioral or psychiatric specialist who provides consultation to the primary care provider for specific case-by-case needs. And then you've got, very importantly, the case manager, who I'll talk about more in a moment, but who performs very many different roles. And in India, could be actually someone who is either sitting in the clinic, such as, for example, a community health officer in the health and wellness centers, but it could also be somebody who is working in the community setting, such as, for example, an ASHA. And at the heart of all these three providers is, of course, the patient, and I would add, in the Indian context, the family of the patient as well. Collaborative care consists of these 5 critical strategies: proactive or opportunistic detection, for example, through screening for depression; interventions that combine both pharmacological and psychosocial interventions that are delivered in a tailored step care manner, and I'll speak more about that in a moment. But important to say, one size does not fit all. You need to tailor interventions according to the needs of the individual, and that, of course, is the hallmark of person-centered care. Continuous monitoring and adherence support, for example, continuous monitoring of mood, and supporting the individual with engaging with long-term interventions. Concern not only with biomedical or clinical outcomes, but also social outcomes. For example, does the person have friends to actually spend time with? Does the person have social support? Does the person have work that they find meaningful and purposeful? Does the person have adequate housing? An active participation of the patient in self-management, unlike what typically happened to my mother, where she would go see the physician and would simply receive a medicine with no real engagement on how she could support her own recovery, with no opportunistic detection of a depression, with no continuing monitoring and adherence support. Everything that care should not be is what my mother had actually received. Now, you remember I showed you on the infographic the important role of the case manager or the community health worker. This is in India, this would, as I said, be a CHO in the health and wellness center or an ASHA. These are the kinds of roles that these frontline workers, I can use that term for both of these different kinds of cadres, could play in a collaborative care model: education, information, supporting with intervention engagement, befriending, monitoring, etc., etc. But in addition, these health workers can also deliver evidence-based interventions for mental health problems, particularly mood and anxiety disorders, through psychological treatments. This is the kind of different roles that the community health worker or the frontline worker needs to be equipped with. And in the second edition of my book, Where There Is No Psychiatrist, which you can download for free from Cambridge University Press, you will find an entire manual that has been designed for frontline workers that covers all the different competencies and interventions that a frontline worker can and should deliver for mental health in their communities. This manual has been based on a large body of clinical and implementation science that has been generated over the last 2 decades from diverse parts of the world, including a lot in India that I'll talk about in a moment, which has shown without any doubt that we know how to deliver clinical and preventive interventions for mental health problems using a variety of different providers, such as what you can see on this slide: a grandmother who has been trained to deliver a 6-session cognitive behavioral intervention for depression. She's delivering this intervention on a bench that has been erected in the compound of a primary health center in Harare, the capital of Zimbabwe. And this lady who she's treating is a mother with depression. This program is called the Friendship Bench and is one of the more than 100 randomized controlled trials that has demonstrated the effectiveness of this approach for treating depression. Now, in the introduction, you heard that I am a co-founder of Sangat, a NGO that which was headquartered and founded in Goa, but now has big hubs in Bhopal and New Delhi and works in more than a dozen states of India. Sangat is India's leading implementation science organization working on innovations to improve access to quality prevention and care interventions for mental health problems. Here you can see a slew of different, the titles of a number of different publications, almost all of which are either in the Lancet or in PLOS Medicine. And as you can see, these are all randomized controlled trials that are examining a variety of different mental health goals, from prevention in school settings all the way through to working with children who have autism, as well as chronic serious mental illness such as schizophrenia, and the treatment of other conditions such as depression and alcohol problems. What this large body of evidence has shown is, first of all, redefining mental health care by redefining what comprises mental health care. Currently, if you do seek mental health care in India, the odds are 99% of the time you will receive a prescription. Yet we know that what most people need and want is not a prescription, but in fact, psychosocial interventions. And what this large body of evidence shows is that these can be brief interventions, as brief as sometimes just 4 to 6 sessions or 30 minutes each, that are typically targeting psychological and social mechanisms of mental health. These are delivered where people are, not where the practitioners sit. And a lot of my own work has involved the delivery of these interventions in patients' own homes. They're typically delivered by providers who are widely available in the community, such as ASHAs, community health officers, and in my own work, in fact, most often by frontline workers and lay people themselves. And importantly, we should really see this extension model of care rather than a replacement model of care. The idea really here is task sharing to frontline providers as part of a collaborative care framework that I spoke to you about earlier that builds coordination between the frontline provider, the primary care physician, and the specialist. Because of course, one size does not fit all. And we need to recognize that while a significant proportion of people will recover with frontline care, there will be a proportion, a minority, but an important proportion who do need more specialized care. In summary, this large body of evidence can be summarized through 4 major innovations. First of all, reconfiguring care from clinics to communities. A stepped care model, this is what I referred to earlier. You start with low-intensity psychosocial interventions delivered by frontline providers as the first point of contact with the healthcare system, involving communities in the planning and the delivering of care, and using digital tools for the workforce, health system, and the affected person. And I'll speak about one such digital tool in a moment. This large body of science is, in my view, perhaps the most exciting body of mental health implementation science to have emerged from anywhere in the world over the last 2 decades, and has been embraced by a variety of different high-level policy documents, such as, for example, 2 Lancet commissions published in 2018 and 2022, which I chaired, one on global mental health and sustainable development, and the second one on depression in particular. The World Mental Health Report of the World Health Organization published last year, and even in rich countries such as the RAND Corporation report on how to transform the US mental health system. At the heart of this transformation is redesigning the workforce from what is currently the case for mental health care, where almost all the money and all the investment is going at the top of the pyramid of care. I don't know how many of you are aware, even today, 75 years after independence, more than 3/4 of all inpatient beds for people with serious mental illness are in colonial era mental asylums, even though our colonizer, Britain, has dismantled all its asylums and replaced it with much more community-oriented care. In India, 75 years after independence, the British era hospitals remain, in fact, the single most important space for mental health care, not just in terms of the number of beds, but also in terms of the amount of money that the public exchequer spends on mental health care. Instead, what we need to be doing is exactly the opposite, which is in fact shifting our resources and emphasis to caring for people with mental health problems in the community, in their own homes, integrated with their other chronic diseases through frontline workers such as community health workers. I want to end by telling you about the platform that we've launched in Sangat in India and at Harvard Medical School in the US that is seeking to deploy digital tools to rapidly build the workforce, the frontline workforce capacity to learn, master, and deliver quality assured evidence-based psychosocial interventions. This platform is called Empower. As one example, we've started with depression, trying to scale up a 6-session treatment for depression that was designed by Sangat in partnership with a global group of partners, including the London School of Hygiene and Tropical Medicine. The trial was with 500 individuals with severe depression attending primary care facilities in Goa, and lay people in these primary care facilities were trained to deliver this 6-session treatment. The results were published in the Lancet and PLOS Medicine and are summarized here on this particular slide. What you can see here is that, of course, 100% of individuals at the baseline of the trial were severely depressed. 3 months after enrollment, those who received the 6-session treatment, 2/3 had remitted. That is to say that depression was no longer evident, as compared to 1/3 of patients in the control arm that received only medication care from the primary care practitioner. 12 months after enrollment, still 2/3 had remitted. And incredibly, a follow-up that we've just completed 5 years after that trial showed sustained benefits 5 years later. Let me say this in another way. 2/3 of patients with the most severe form of depression, this was not mild to moderate depression, this was severe depression. 2/3 of these individuals not only remitted, but stayed well for 5 years after receiving what was in total about 3 hours of intervention by a layperson delivering a psychological treatment, just 3 hours. And of course, this is what the heart of all psychological treatments are. Unlike medication, the focus goes on supporting a person with building their own skills to deal with the difficult social problems that they face, which are so commonly the reason why people become depressed. Now, equally importantly, it's important to remember that 1/3 of the patients did not recover. So this is 1/3 that will need, in a collaborative care model, interventions from the specialists, which could then also include the addition of antidepressant medications, and for some individuals, they may need something more, such as, for example, ECT. Empower is deploying technology in multiple ways. We have designed a methodology to move from a curriculum, that is to say, a manual of an effective intervention, and to create a competency-based, digitally delivered curriculum that can be delivered on any learning management system. We've designed ways to deliver assessments of competencies, both knowledge and skills, remotely. Working with the tech company Dimagi, which runs the largest community health worker technology platform in the world, including in India, we've designed an app for the measurement of supervision and quality of the therapy that is delivered. And we are, as digital data is being generated, developing data science-driven evaluations that really help unpack what determines good competencies in the ASHA or CHO, and how does and what aspects of quality predict patient outcomes. As we speak, this incredible work is now being scaled up in the 3 districts of Madhya Pradesh in central India through ASHAs. This scale up began only about 6 months ago, and in the last 6 months, 500 ASHAs have completed training, are now proactively detecting individuals with depression in their communities, and at last call, more than 2,000 patients with depression have received and completed treatment with astonishing treatment completion rates of 95%, with almost 100% remission rates in the people who completed treatment. Also very exciting for me, since I joined Harvard Medical School 7 years ago, has been the enthusiasm in the US to bring this model designed in developing countries, including India, to the US, and in partnership with the American Psychological Association and partners in Texas, we are now scaling up this approach, including the 6-session treatment that was designed in India, in the US. I don't think it's very often that you hear innovations developed in India being exported to countries like the US, but that's exactly what's happening in this instance. We're also delighted that this scale-up effort has won the Lone Star Prize, a prize that was awarded to us 2 years ago for innovative examples of how one can improve the lives of people living in Texas. That's why it's called Lone Star, because Texas is called the Lone Star State. And so with that additional prize money, we are now working with hospital systems in Texas to use Empower to build the capacity of community health workers in the US to deliver this depression care. I want to end by saying something about going beyond individuals, which has been really traditionally the focus of all medicine, is we treat not just the individual, but a particular disease in an individual. Going back to my mom, this is my mom in the last few years of her life. You can see the picture is not entirely complete because it doesn't include my father. My father was her primary caregiver right through the last 10 to 15 years of her life when she was increasingly sick. And as you can see, my father, who's still alive and well, but increasingly struggling with his own chronic diseases, is obese. What I find incredible is that through all the 15 years that he used to accompany my mother to all her very many different doctors in all the Tony private hospitals in India, not once did any of these doctors ask my father how he was doing. And over this time, they could see my father putting on weight. Not once did they ask him, are you okay with your food habits? We know that depression is associated with obesity. Are you overeating? How is your overeating affecting your blood sugar? Not once did anybody ask my father how he was doing. And of course, this is not true only of India. This is how medicine has been structured. Our focus is on diseases, not on individuals, and not on the ecosystems that they live in. Yet, families matter. Along with Shivangi Patel at Emory University, I mentored the analysis of a large data set from India, which luckily had actually data on multiple members of a household. Typically, when you look at epidemiological data sets, we only use one member of the household because we don't want there to be clustering, which is ironic, because actually the really interesting question is, do these different chronic diseases cluster in the same household? Because that tells you something about household pathologies rather than individual pathologies. And that's exactly what we found. Irrespective of genetic relationships, adults who resided with another adult with a chronic condition had a 30% increased adjusted relative odds of having another chronic condition. And this was true even across different chronic condition phenotypes. For example, if I lived with someone with hypertension, let's say, for example, my mother had hypertension, I had a 35% increase odd of obesity. This means we should be moving from the notion of sick individuals to sick households and being increasingly concerned with supporting households or at least primary caregivers in a community-based way of delivering care. So when we think of re-engineering how we respond to chronic conditions, and this of course includes palliative care, we go from the current approach of treating specific diseases by specialists in hospitals to integration of specific diseases in individuals in primary care, to management of multiple morbidities in primary care. This is of course person-centered care, and ultimately to community-based care that supports households through addressing impairments and risk factors that operate at the household level. This is my last slide, but I hope what I've left you with is a sense that we have got the resources, we have got the knowledge on how we can improve access to affordable and quality mental health care for all. For too long, we've had this kind of very negative approach, which is thinking, oh my God, we can't really address mental health problems without psychiatrists and psychologists, and who is going to go to see a psychiatrist, given all the stigma attached to psychiatry? And when they go to psychiatry, what they're going to get ultimately is just another prescription. Does that really address the complex psychological and social needs of individuals? Well, friends, I hope I've inspired you with the knowledge that's come from India and is changing the way mental health care is being viewed across the world, that we do know how we can deploy resources that every community has, people who care for each other. And we do have ways in which we can address psychological and social issues by addressing those both at the level of the individual, but also at the level of the family. Thank you very much.
Thank you, Dr. Vikram Patel. And I would like to reflect on what you have been talking. So there are 2 or 3 points which I would like to take up from your presentation. One is that we should invest more on community health, not in the big hospitals or where, and that care is affordable only to a minority of patients. Whereas in the community, there are a lot of patients who is unable to access any type of care. So if we can invest more on community, we'll be able to reach many. The second point is which as palliative care healthcare professional, we all usually do that, and not only Actually, palliative care is concentrated not only on patient but also the take care of the family. So we usually ask the caregivers, how are you doing? Or are you suffering from anything, etc., etc. Their psychosocial suffering, etc. But those are very small points, but it can make major impact, and that's what you have narrated your own personal experience and what has happened to your father. So thank you, Dr. Vikram Patel. Um, Thank you very much. And now I would like to open this forum for discussion. Anybody want to start? So,
Hello,
Dr.
sir.
Vikram Patel, yeah, one question by me. So you have been doing the work with Sangat in many states of India, and you have been using an learning platform for the lay people to learn on the therapies that need to be provided in depression. Is that really available in India, or can somebody partner with you, or would you be willing to partner with anybody in delivering this?
Absolutely. Yeah, no, thank you for that question. It is very much available in India. In fact, it's, it was started by Sangat. So it's an Indian platform, which we are now adapting actually for use in the US. So you can, and the depression treatment is available in Hindi and in Gujarati. Obviously, if you want it in another language, it needs to be adapted. There's also other treatments that are available. One for autism, which is being scaled up in districts in Delhi, in Goa, in Sri Lanka, and in Nepal, and also a third one for adolescents with mood and anxiety conditions, and a fourth one which is now being developed, a curriculum for peer support for people with chronic enduring mental illness. So all of these are being developed in India by Sangat, and I'd be very happy for anybody who is interested to adapt or to partner with Sangat. I'd be very happy to introduce you to the lead program. He's a psychiatrist, Ravindra Agarwal, who leads Empower in Sangat.
Thank you. Anybody else want to ask?
Thank you very much for the inspiring session, sir. I would like to know about the target audience, other than the ASA workers from India. Who are all the target audience to this Empower program?
So, it could be anybody. Honestly, I wish all the psychiatrists would do it, because most psychiatrists don't actually know how to do psychological treatments themselves. I would say certainly anyone who is engaged with mental health care, from ASHA to a CHO to nurses to primary care, whoever is wanting to learn. Honestly, the whole point of task sharing is, what is the minimum qualification you need in order to be able to deliver a health intervention? There is no upper qualification. It's the minimum one. And so what we've been able to show through this large body of implementation science is that the minimum qualification is that you're literate, which is, what an ASHA worker is. But there is no upper limit.
Anybody else?
Dr. Patel, sir, how do you assess the mental status of these patients by the ASHA workers? Is it by questionnaires? Is it by direct interaction?
Yeah. Sorry to interrupt. Yeah, you're absolutely right. Unfortunately, the mental health field hasn't got anything more than self-report. Honestly, this is one of the great challenges for outcome assessment, for impact assessment, is that we have to go back to the individual and collect data. But I guess this is the same as palliative care. I think there's a real parallel here. There is no biomarker for pain. You're relying on individuals' self-report. So really the emphasis is using validated measures that are relatively brief, therefore they can be used in routine care. So these are not research studies. And luckily there are, for depression, there is in fact a very brief measure, which is now part of the National Health System Resource Center's guidelines for primary care. So if you look at the NHSRC guidelines for health and wellness centers, you will see that that the PHQ is being recommended as the measure for depression. It's been very widely used and validated in India, and that's the measure we also use in all our work. Partly because it's there's so much evidence on its user acceptability, and also it's very brief. It's you can ask just 2 questions. And then for people who respond positively to any of those 2 questions, you ask another extra 7 questions. And then that score will give you a calibration of the person's degree of depression, if they have any, including moderate and severe.
Is there any other way of proactively knowing whether a person is depressed by the care workers?
I mean, there is a lot of work being done to try and use, what's called digital biomarkers is the most promising, where you use a person's app. There are apps that you can download on a phone. It's one good example is MindLamp, which is actually being used by Sangat in a study for people with schizophrenia in Bhopal and with NIMHANS in Bangalore. What it does is it passively collects behavioral data from your phone. For example, your sleep patterns, your mobility patterns, your social contact patterns. For example, how many people you've called in the last 24 hours. It's fascinating how you can harness data from the phone that actually is a proxy measure of your behavior. And of course, all behaviors are very powerful predictors of mental health, particularly sleep. And so that is something you could use, but I really think it's still very much in the early stages of validation. There's also questions about privacy and so on and so forth. So I would say the most useful techniques we found is to train the ASHA to identify high-risk groups. For example, a person with chronic diseases, painful conditions, people who have had a bereavement, people who are living alone. There's a bunch of well-recognized high-risk groups. And in those individuals, you do proactive screening. So you may not do universal screening because that might be considered too much in an under-resourced system, but you can do opportunistic or selective screening based on certain recognized risk factors for poor mental health.
Thank you.
I mean, I would say anyone with terminal conditions who is receiving palliative care would be, in my mind, a high-risk group. So, I think certainly for anyone working in palliative care, I would say you should make this part of your routine assessment of the individual.
Thanks.
Sir, in that case, the trial you have mentioned, I think it's on the general patients that had been but with the 60% reduction in the mobility of psychiatric illness.
Of depression.
Of depression, right? So can we whether this model can be replicated or can be in a palliative care setting?
Well, I think it's a good empirical question. I don't see why not, but equally, I think it's always a good idea to do an evaluation. I'm not suggesting you need to do a randomized controlled trial evaluation, but if that was possible, I think it would be a terrific opportunity to do that. The 6-session treatment's now been evaluated in 3 other trials, one with people living with HIV in Uganda with incredible results. So there is a large body of evidence already on its effectiveness in different contexts with different groups of patients. I would be surprised if for any reason it didn't work in palliative care. But it's certainly worthy of some kind of evaluation to examine whether it works or not. Or rather, let's put it this way, who it works for and who it doesn't. I think that's a more interesting question because obviously the people for whom it doesn't work will need something different.
Yeah, maybe if it doesn't work in the palliative care setting, maybe it helps in the refining the approach, or maybe we can take it as a template or a baseline
Exactly.
model,
Yeah.
so that we can improve upon to push it upon the palliative care settings.
That's exactly right. Absolutely.
Thank you.
Just to add to that, I guess that there also have to be some consideration of kind of prognostic expectation and functional capacity. I mean, the work sounds fascinating, and opportunities in palliative care sound really very extraordinary. But again, we're dealing with patients for whom time usually is not our friend. And so looking at brief interventions are important. Successions, it reminds me a little bit of the work of William Breitbart, meaning-centered psychotherapy. Again, they have 6 to 8 sessions. So it's not as if multiple sessions, are precluded from palliative care. But again, one has to look at the trajectory of the individual who's approaching death and see whether or not this will be viable and for whom.
Yeah, I completely agree, Harvey. I do see that people who are receiving palliative care do form a very unique group of individuals, and the kind of horizon, the time horizon that we're thinking about is obviously different, and building skills that have a long-term, sort of implication may be less immediately relevant. Yeah, I agree with you.
It'd be interesting to think, Vikram, about some kind of a multi-session intervention that could be designed for family members who are struggling with all of the various different challenges that they face during the course of their loved one's ailment. I mean, again, these are people who oftentimes are overlooked, underserved. You mentioned, your father, and how no one asked him during the course of your mother's illness how he was doing. Well, wouldn't it be interesting if you might be able to adapt the model that you've developed and do something for family caregivers, especially if, and I don't, especially if it could be done virtually, then, might family members be able to avail themselves of this over the prolonged periods of time, that they spend looking after their loved ones? Because the course of, active dying is a relatively truncated period of time, but the reality is that somebody who's dying of a solid tumor, an advanced malignancy, even neurodegenerative conditions, these are conditions that are relatively protracted, and the needs of family members might be something that you might want to give some thought to in terms of adapting the model that you've developed.
Well, actually, honestly, Harvey, I completely agree with you. I just personally have not had that the bandwidth to do that, but I've always been a hugely great supporter of the idea of family-based interventions, and I hope that will be one of the young people who are involved in this course might see this as something that they might want to actually pursue.
I like that. We need to look for young people with bandwidth.
Sir, you can.
No, Sunil, I think I'll let Smriti go first.
Yeah.
Thank you, Raj. This has been absolutely fascinating and very vital session, I think, because we're also, I think, struggling with the continuum between palliative care and mental health. And, although we emphasize an interdisciplinary team, I don't see very many people trained in counseling skills or, there is, of course, like you said, Dr. Patel, that, look at the minimum qualification, but even that requires a certain degree of training to apply it in the field. And here, I just want to say that we're sowing the seeds. We've been talking to Dr. Shibani Majumdar also about developing a module for caregivers, both practical techniques in caregiving as well as emotional and mental health support. And the idea so far, it's very nascent, so I'm just putting it out here. It's not anywhere close to being complete. Is that there is the practical aspects of direct care that you provide to the patient, which is hygiene, cleanliness, wound management and so on. But there's also stuff like, caregivers feeling so helpless. They don't know when to go to the hospital, when not to go to the hospital. So equipping them with that information, saying that this can be managed at home like this. And the way we're looking at it is going maybe, neuropalliative care, respiratory distress issues and malignancies and so on. But what you're saying is really interesting. And Harvey, I put that in the chat box just as you said it. I think this is where the continuum can begin in terms of, bereavement can be a very, very difficult and complicated experience. And then you're left with the patient has died, but you're left with somebody who's invisible, like you said, and who, Dr. Patel talked about high-risk people. I think bereaved people are at very high risk for mental health issues. And this could be the point where we can tie the whole thing up together. And so maybe we can have a longer conversation, Dr. Patel, about, just some advice on how this can be incorporated into the caregiving, for the sort of self-paced program that we're developing for caregivers as well, because that's absolutely essential what both of you are talking about.
Sunil, may I?
Yes, sir.
First, for your Harvey and Dr. Patel, for your information, it's not only people with terminal illnesses that we look after. In India, with the huge gap in primary care, that seems so totally unfair. We look after all serious health-related suffering, which means in our list in Trivandrum, we have about 130 people with paraplegia. People following stroke come to us straight from the neurologist, and their rehabilitation and recovery is part of what we do. So all this, in that context, becomes even more relevant. The second point is to ask you about a couple of potential challenges. The big problem that I see in front of us, both with dignity, restoring dignity therapy, and with mental health care delivery, using the community volunteers, is that the problem is both are very inexpensive. And both do not require expensive healthcare professionals. Now, this is going to be a challenge. Already, there will be so much of opposition. We are very careful in what we say when we talk about community volunteers. What you are proposing is going to violate the big powers, the healthcare industry. It doesn't suit them. Unless you invent a very expensive machine to deliver dignity therapy, and even more expensive one to diagnose and treat mental health disorders, this is going to be tough. The only way, you are already showing it, Dr. Patel, in Madhya Pradesh, the work of Sangat is so inspiring. And here, let me tell you what we have here. In Kerala, there are more than 10,000 active volunteers, spread out over more than 400 small non-governmental organizations in localities, many of them eager for knowledge. We haven't got around to making proper use of their services. And to all the participants from outside Kerala, you are going to learn a lot of inspiring lessons from wonderful teachers during this course. But if there is one thing that you must resolve to do, I would say it's about engaging with the community. It's easy to say, it's easy to do also, if we set our minds to it. If you are careful not to be lynched by fellow professionals, this is doable. And then we'll be able to put into practice what these two phenomenal people have taught us today.
Well,
Yeah.
thank you. Professor Rajgopal, first of all, thank you for that comment. I think you're absolutely right. You've hit really the elephant in the room. I mean, every effort to actually produce an equitable, affordable, and evidence-based healthcare system has to address the structural forces that actually are against that very mission. And I want to actually quote my late department chair, Paul Farmer, because I think that the way he describes this is exactly right. In his words, we thus find ourselves at a crossroads. Healthcare can be considered a commodity to be sold, or it can be considered a basic social right. It cannot comfortably be considered both of these at the same time. This, I believe, is the great drama of medicine at the start of the century. And this is the choice before all people of faith and goodwill in these dangerous times. Close quote.
Yeah, thank you. Please share that with us. That is so powerful.
Wonderful.
Well, thank you all. I'm going to have to jump off to teach a class now, but it's been a real pleasure. And Harvey, it was a delight to actually meet you, if only virtually. Thank you so much. I really enjoyed your remarks. And I certainly think when I was listening, I was thinking of my mother all along about the question of dignity, and how oftentimes the one thing that she wished she had a lot more of was not more doctors and medicines, but just simply more dignity. And unfortunately, our healthcare system could also do a lot more with giving people dignity in every healthcare encounter. But thank you all. I need to go. It's been a wonderful engagement. Thank you.
Thank you, Dr. Patel.
My pleasure meeting you as well, and my pleasure being able to spend this time with all of these wonderful colleagues in India.
Yes,
So I think we can wind up the session now if there are no more questions. Thank you, Dr. Chochinov, for your inspiring talk on concentrating on persons. So that will give more information to us, and we can take care of them in a very good manner also. Thank you very much for finding out time for us.
Thank you. It's been a pleasure. And wishing you all well in the remainder of the course. Goodbye from Canada.
Dr. N.S. Raju from Andhra Pradesh has written on the chat box, among the best sessions I have ever heard. Thank you, Harvey. Thank you, Dr. Patel.
Thank you, Raj. Bye-bye.
Dr. Rajgopal, sir, I have got one question to you.
Yes.
So you said about disseminating this information through the community. How do you approach the volunteers from our side? I mean, what can we do to enlighten them, to train them? Because where do we find them? How do we approach them?
Sunil, Dr. Biju, thank you. Sunil, I hate to keep troubling you and disorganizing all the beautiful schedules that you have made. But somewhere we have to squeeze into our program the answer to Dr. Biju. This question is vital, and it cannot be squeezed into 10 minutes. We have to provide everybody a roadmap for making the for engaging the community, how that can be done. And then
we have already planned a session. And that would be an on-site session where when they come for hands-on training. So that would be done by a group of volunteers.
okay, you have already planned it, so I'll leave it there. But I was still wonder if prior to that, the volunteers, we'll talk about it. Dr. Biju, I'm sure I cannot answer that question in 2 minutes, and it's already 8:34. But
Yes, sir.
certainly, I would like you to correspond with you on that matter. Please feel free to email. But
Yes, sir.
also, I'll discuss with Sunil and see if anything more can be done to make that an organized exercise, not just a casual conversation with volunteers.
Yes, and this is very important because we are facing roadblocks when we are approaching our colleagues, as I told you last time.
Yeah, of
So
course.
it's very difficult to bypass that and directly go to the people. I am trying to find out ways how to approach the people, the mass of people who don't even know that, palliative care means much more than just giving morphine. And this is something which I'm trying very hard to achieve.
Yeah, Dr. Biju, we must talk about it, and to everybody.
Yes, sir.
If we do not really get to this point, we'll continue to do the time-honored hospital-based air-conditioned consultations and nothing else. Sunil, I suppose formally you may have to close the session, but is it possible for us, Sri Priya? I don't know whether Sri Priya will be very annoyed. Is it possible to continue an informal discussion to, I think Punita is going to be very angry if her raised hand is not responded to, and Smriti is joining the fray.
Sir, I wanted to answer Biju sir's question, sir. When I was at Pallium, I had these social officers giving me a very good introduction on how to handle community engagement programs. I think Mr. Babu and his team, these social officers, when they took me around Pallium, they gave me a good, easy roadmap of like how they involved college students, how they involved some IT company people, how they approach a senior citizens group and all. So it was a good way of learning, I thought.
Punita, the point is you learned it, but we have to plan a practical session of engaging the community, everybody, and which is why I was wondering, when you come here, will that be early enough? Can we create some kind of an engagement mechanism? We haven't done this before. We will have to create something new, but it needs to be created. Some structure to the course so that everybody makes one practical effort of engaging with somebody in the community and making them a partner in some way or other. Maybe advocacy to start with. It would be really a worthwhile effort. But Sri Priya, though she didn't agree, at least did not say no to extending an informal session, continuing it. So Smriti, your hand is up.
Thank you. Very important question from Biju, and thank you, Punita. I just want to make 2 points. One is that there is still some, 3 points. One is the Kerala model is respected, it is celebrated. I'm a big fan of it. I mean, I've been with Pallium for 10 years, but I'm also very aware of the fact that this is not a model that can be replicated everywhere else. There are certain moving parts that need to come together. Kerala is unique in many ways. The moving parts that came together in Kerala to deliver this community-based palliative care model, there might be elements of that missing in other places. We need to be very mindful of it, realistic about it, because we need to look for strengths in our own communities, whether they're in a rural part of Andhra or an urban part of the NCR or wherever it is, because the strengths are different. Mizoram, it was the Presbyterian Church that came in and brought palliative care into the community. So let's be mindful not to try and transfer the Kerala model, but to translate its strengths to our own community. So exercise number 1 is maybe a SWOT exercise of your community strengths, weaknesses, challenge, whatever. The second point I want to make is that palliative care is still a phrase that is resisted by a large number of people, not just in the medical fraternity, but also in the public, because of this narrative of it being end-of-life care, terminal care, etc., etc. Even doctors will not refer because they say we are not there yet. How much suffering does someone have to endure to be eligible for palliative care? I would say there's a quote, there's only 4 kinds of people in the world: those who have been caregivers, those who are going to be caregivers, those who are caregivers, and those who are going to need care. if it is easier, let's use that rhetoric also to engage the public, because that is something everyone can relate to, bring in the palliative care narrative into it. And I would invite you to join us to create this model where today, after the COVID pandemic, we've all intimately been associated with serious health-related suffering, if not before that. The last point I'd like to make is that we are, again, in the beginning of what we are calling a death literacy campaign. And the death literacy campaign is not just about death and dying, it's about the process leading up to it and the bereavement process as well. It is being led by community members who did the Arohan program with us. Jagriti is very familiar with it. So this is a program designed and led by people who have lived experience. We had one session on advanced care planning done by somebody who really felt a lot about it. We had another session on estate planning, which I can tell you, I learned so much in those 2 hours about estate planning, because serious health-related suffering also takes into consideration what happens to the people, at that time. So this is basically what I'm trying to say is an open invitation to collaborate, in the words of Dr. Vikram Patel, and happy to have a longer conversation. And I'm just delighted that doctors are taking an interest in this and it's not being left to psychologists and social workers and caregivers. So sorry about the long ramble, but maybe we can find ways to work together on that.
Thank you, madam.
Okay, Punita. We are already doing a course for anyone those who are not doctors or nurses. That is certificate course in foundation course in palliative care. And also there is some another course on psychosocial support. So these are the 2 courses available as of now for those who are not doctors or nurses.
Okay, everybody, good night.
Thank you, sir. Thank you so much.
Thank you,
Bye.
Sunil. Sri Priya,
Priya.
thank you.
So thank you everyone for joining in. I believe our sessions are becoming more and more interactive and informative as we move along. So please do stay tuned and wait for the next session, which is going to be another different topic and yet and more veteran speakers joining in. So this is Sri Priya, along with the Dr. Sunil Kumar and our distinguished guest, Ms. Smriti Rana, signing off from the Pallium India's presented. See you in the next session. Till then, everyone, take care. Bye-bye.